Thanks very much, Krish, and thank you to the Association for the invitation to speak today. It's a real pleasure and an honour. And I'd like to share with you some of the insights from the NAP7 project regarding intraoperative monitoring in this kind of intraoperative phase in the middle of the seminar. So I guess the question is, why do we monitor patients? Sorry, to make sure my clicker's working. No, why do we monitor patients? And it's something that we do routinely every day for every patient. We put on the ECG, the SATs monitoring, the blood pressure cuff, and most of the time, thankfully, most of our cases are fairly uneventful, but monitoring really is there to alert us to when patients are becoming unstable or maybe becoming at risk of serious complications. And I think the key standards are those really set out by the association, which were updated in 2021, the recommendations for standards of monitoring during anaesthesia and recovery. And they say that the key kind of reason for doing it is that monitoring will not prevent all adverse incidents or accidents in the perioperative period. However, there's evidence that it reduces the risks of incidents and accidents by detecting the consequences of errors and by giving an early warning that the condition of a patient is deteriorating. And I think that it's really that latter thing about deterioration or of the patient that's the key thing. And whether it's an early warning is something that we might come back towards the end of the seminar to think about if our warning about patient deterioration could be even earlier. So to think about where we are in terms of monitoring today, we can kind of go back to maybe where we were in the 1840s when anaesthesia on people, humans, was first used. And I guess this is my kind of interest from the perioperative cardiac arrest perspective. So this is John Snow, and he put together a series of a case series of what we'll call the on-the-fatal cases of the inhalation of chloroform. And this poor young girl, Hannah Greener, is really the claim to infamy really for the Northeast. She was from Newcastle upon Tyne, and she was having a toenail removed, and she'd had a previous uneventful anaesthetic, but on the second one, sadly, she succumbed to chloroform. And you can see here in the margins of the register of the death that somebody's written that she died from the effects of chloroform, underline. And when you read the description, a lot of the things that happen, it sounded like her airway became obstructed, it sounds like she aspirated and then became pale and unresponsive, are things that we would hope wouldn't happen today with modern anaesthetic techniques and with modern anaesthetic monitoring. And so from that point to today, we've had a journey in monitoring practice. John Snow, in the wake of that, apologies, the children are running around upstairs, advocated for monitoring of respiration depth and frequency. And then that moved on towards more cardiovascular kind of signs with fingers on the pulse in the late 1800s. And then it wasn't until the early part of the 20th century that we were able to do non-invasive blood pressure monitoring and ECGs, albeit they weren't continuous. And that didn't really come until the middle of the 20th century. And then more recently, neuromuscular blockade monitoring in the 60s. But within most of our lifetimes, we saw the introduction of the first commercial pulse oximeter in the late 70s and the routine use of capnography in the late 80s. I guess the question is, why did these things happen? Well, I think there's two things. One is a drive for patient safety, but there was also, particularly in North America, a great desire to avoid litigation. And this is a very North American perspective on this, but you can see that, as recently as the mid-1980s in North America, there was a lot of concern about rising anaesthesia malpractice premiums, particularly in and around Harvard Medical School. And they began to address that by doing, in some ways, kind of what we do in the national audit projects. They look at closed claims, so closed insurance claims as a way to learn, where we have more of a confidential inquiry type model. But as a result of that, things came in, there were standards set, and for the North Americans, the key thing here was that this initially decreased their malpractice insurance premiums, and those who could show that they were practicing more safely with pulse oximetry and capnography got better insurance premium discounts. But what about when things do go wrong, and even in the UK? So this is a study that Fiona Oglesby down in Bristol published last year, and she looked at all of the claims and litigation went through NHS litigation from 2008 to 2018 regarding anaesthetics and anaesthesia. And there were about 1,200 claims that went through, of which 22 of those were directly related to monitoring, which doesn't sound that many, only 2%. But it's quite insightful here. They say that monitoring claims included a failure to promptly identify adverse events due to poor monitoring or inappropriate interpretation of monitors, and failure to promptly detect and respond to low blood pressure, leading to neurological injury and/or cardiac arrest. And although they weren't that common, I think it's interesting to say here that they were amongst the highest ranking in terms of payouts. So the mean cost was second only to cardiac arrest of 130,000. And when you look at the kind of impact that they were having, when they looked at the ratio of either low to high impact, a lot of these claims for monitoring deficiencies had severe or fatal outcomes. So potentially when we're not monitoring our patients adequately, there's potentially serious implications for our patients. So what are the monitoring practices in the UK today? Now, we're extremely blessed as a community of anaesthetists that we come together every 3 to 4 years to undertake national audit projects, and people put in a lot of time above and beyond their normal day job to do this. And the most recent one has been focusing on perioperative cardiac arrest. And the final report is going to come in November this year. But we don't just get data on a particular topic, we get a lot of other kind of friendly fire data, if you like, that nuances the project. And people will be familiar with this. I won't spend too much time, but there's a baseline survey within the project where we ask people's personal experiences of perioperative cardiac arrest, and over 10,000 of you responded, and we're extremely appreciative of that. There's the case reporting registry, where for a period of 1 year between June 2021 and June 2022, all cases of perioperative cardiac arrest will have been reported. And we had almost 1,000 cases in the data for that, and that provides the numerator data, that's the 1 in X. And the third part of the project is the activity survey, which again, a lot of you will have participated in at the back end of 2021 in November. And this was a 4-day survey of all cases that all anaesthetists did at their site. And we had over 24,000 cases submitted. So just to remind you, it was this time it was an electronic survey. Everybody got sent a link. We did it continuously for 4 days on each site, and each site was randomly assigned a day of the week with equal chance of starting on each day. And we collected data on cases by anaesthetists, including those on labour ward epidurals, but not critical care cases, not transfers. We collected patient characteristics, some surgical details, and critically some anaesthetic details, including monitoring. And of the 416 NHS sites across the UK that we invited, we got responses from 85% of them, which is incredible. And as I said, over 24,000 individual cases, which gives us an estimated annual caseload for that period of about 2.7 million cases annualized. And what we were able to do was to compare some of the response really against the standards that had been published earlier that year by the association. And I'd like to run through a couple of those with you now. So one of the standards was was about monitoring during general anaesthetics. So it says that it requires a minimum monitoring of ECG, SATs, and non-invasive blood pressure and capnography. And reassuringly, the response to this was that pretty much everyone did that 100% of the time, which is excellent, and that's the good news. When we move on to other areas, though, for sedation, the guidelines suggest this requires a minimum monitoring of ECG, SATs, and non-invasive blood pressure, and that capnography should be used during procedural sedation whenever there's loss of response to verbal contact. Now, if we sort of increase the sedation level here to look at deep sedation, moderate sedation, and minimal sedation, you can see that pulse oximetry has a pretty high compliance rate. There's some suggestion that non-invasive and ECGs aren't used in all cases, but here you can see that capnography, in the case of minimal sedation, is only used just over 50% of the time. And there's a clear sort of trend that as the sedation level is less, capnography is not used. And now it's difficult to say, I think, where you might expect a loss of response to verbal contact. And so where you decide to draw the line here, I think, is interesting. We're also asked about transfers of patients, because we thought that the period of transfer from a perioperative cardiac arrest point of view, from the anaesthetic room into theatre, and then theatre into either the recovery area, PACU, or critical care, may be risky parts of an anaesthetic. And when you look at ECG sats and non-invasive blood pressure monitoring, only 2/3 of anaesthetics where that happens, only 2/3 of anaesthetics where there's a transfer from an anaesthetic room to theatre are monitoring continuously during that period. And even less, only 57% are monitoring in the process of moving from theatre to either recovery or the critical care unit. And then, of possibly more concern, we asked that if an airway device was in place, whether it be an LMA or an ET tube at the end of the procedure, was end-tidal CO2 monitoring used for the transfer to recovery or critical care? And only 27% of cases where that was the case, CO2 was monitored. Now, I want to take a little bit of a diversion at this point, and really to say that the first paper from the NAP7 project came out last week in Anesthesia and is freely available, and we're very appreciative to Anesthesia, the journal, for promoting that and doing that. It's excellent. But whilst it looks like there's a big NAP7 panel there, the list of collaborators is absolutely huge. And I just wanted to say thank you to everybody who contributed as a collaborator. So these are all the local coordinators, trainees, staff and associate specialists, research nurses and others who collected data during the activity survey part of the project. And the data is really important, and it does have impact for monitoring and theatre. So first of all, what we've seen, and we're able to compare between 2013, which is the NAP5 project, and 2021, where we did the NAP7 activity survey, we've seen a few quite impressive and concerning trends. First of all, that the age of the surgical population, or patients that we look after, the median age has increased from 50.5 years to 52.8. That's an increase of 2.3 years. And if you look at the relative proportion of patients, in ages 56 and above, in all of these groups, the relative proportion has increased, and in the relative proportion of those younger than that has gone down. So we're really shifting towards a more aging population of patients that we look after as anaesthetists. We're also able to look at the distribution of body mass index. So this is how it was 10 years ago, and in NAP6 there was a suggestion that the population we were looking after was becoming more obese. And I think that following COVID, we've seen very dramatic changes in the distribution of patients that we look after. So there's an increase of 8.5%, nearly 9% as a relative proportion of patients who are obese coming for surgery. And I think it's fair to say now that the median BMI was normal 10 years ago, and it's now well in the overweight range. And in the obstetric population, these changes are even more dramatic, over 12% if you add up all of these extra patients who are obese in the obstetric population. And then in terms of comorbidity, well, there's a very basic measure of comorbidity, of course, is the ASA scale. So ASA1, these are fit and healthy patients. They were 38% of our workload 10 years ago. It's now down to 24%. And there's been corresponding increases in ASA2 and in ASA3 patients over the same period. So quite a dramatic shift in the amount of comorbidity that we're having to manage. And I think that really is important in the context of what Ramani was saying, where there's a lot of disease out there that we're going to have to manage as anaesthetists and as perioperative physicians, especially when you put it in the context of the waiting list is going up and up. So there's lots of high-risk patients, and so monitoring these patients, of course, is more crucial than ever. What about some good news? We also looked at anaesthetic practice. So we found that for those of you who are advocates of total intravenous anaesthesia, the proportion of patients or proportion of general anaesthetics was around 8% in NAP5 and NAP6, and it's really gone up over threefold in that period now to over 26%. But with a monitoring point of view, how does that fit with the use of processed EEG? It says that the guidelines say that it should be used whenever TIVA is used with a neuromuscular blocking drug. And what we have seen is that processed EEG monitoring was on the increase between NAP5 and NAP6, so about 30% of cases that were having a TIVA anaesthetic had processed EEG monitoring during NAP6, and that's gone up to 60%. Now, what we don't know is how many had neuromuscular block or not. I suspect that those who had neuromuscular blocking agents are even higher, probably 80 or 90%, which is good news. And interestingly, we've seen that there's a sort of tendency for processed EEG use to increase across the board in all general anaesthetics, mostly driven by TIVA. But it's interesting to see and think about whether or not we're using it for other things. So the guidelines say that it should be considered during other anaesthetic techniques, including inhalational anaesthesia for the high-risk patient. And are we doing that? Well, there's some suggestion of increased processed EEG use with age, ASA, and clinical frailty score. So here, for example, for age, this is the relative proportion in each group who are having processed EEG monitoring. And whilst TIVA in children, people are not using as much processed EEG monitoring, but in adults, it's pretty uniform. In terms of volatile anesthesia, it's pretty much not used in the young, but there's some slight increase in the more elderly patients. High ASA patients are getting it a little bit, and the frail patients are about twice as likely as non-frail patients to have it, but it's still a long way behind its use in TIVA. And I guess the question is, why are people using it? And I think it's because we're moving from using monitoring not only for alertiness to potentially serious errors or disasters in theatre, but from moving from that to trying to improve outcomes. And there's lots of evidence that suggests now that maybe the mode and quality of anaesthetic delivery may impact patient outcome, whether it be depth of anaesthesia, pain, hypotension, volatile versus TIVA, hypoxia. And just as an example of that, this systematic review about intraoperative hypotension suggests that if you have here a mean arterial pressure that's less than 65 for only 5 minutes, then you begin to be more at risk of acute kidney injury. And again, if it's below 60 or 55, you need shorter periods of time where you're at more high risk of dying or having acute kidney injury, myocardial injury, and so on. Now, whether or not treating that reverses that benefit, or whether this is just a marker of kind of cardiovascular fragility, is still up for debate. But what we do also know is that we're not brilliant at treating hypotension, and what we say and what we do are different. So this study from Wickham and colleagues, which was done as part of the one of the RAFT studies, asked people when they intended to treat a given blood pressure. So most people here would say that they intend to treat blood pressure when it goes down 20% from the baseline. But the darker bars actually show us where we do it. We don't do it until it's 30, 40, sometimes 50% down from the relative drop from the baseline. So what can we do to try and improve our reaction to hypotension? There's various things. I think one thing, which if you're a clinical director or if you're into QI, you could just go around and change all the alarms on the machine so they're 10 millimeters of mercury higher, and that might just annoy people into doing things. But we could do other things. We could, for example, put an arterial line in before induction. This study, the AWAKE randomized control trial, which was performed in a single center in Germany, came out last year, and it's no surprise that if you put an arterial line in pre-induction, get continuous blood pressure monitoring, your dips under your desired mean arterial pressure are shorter and less severe than if you have a non-invasive blood pressure cuff. But what else might be coming? And I think this comes to the idea of early detection and what is early and what is not so early. And whilst I don't particularly like analogies from the aviation industry, I think this is one that we could think about. So if you're an aeroplane, you're going to have an altitude, you're going to have an attitude, that's your up-downness, you've got a speed, and you've got a bearing or a direction. And you know, an air traffic control knows where you are now, and they know where you're likely to be in 1 minute, 5 minutes, 20 minutes time if you carry on at the same, under the same conditions. And equally, if you start deviating away from that, then you get an alert, and you get that alert before something disastrous happens. In this case, it might tell you that there is terrain coming up and you're going to move your course to go somewhere more safe. And I think this is the key thing, is that a lot of our monitoring at the moment is set for when we are about to have something that may cause harm. It might be that it's a mean arterial pressure of 65, or it's a SATS of 90 or 93. But actually what we need to know is things earlier, and there are things that we might be able to do using artificial intelligence and machine learning, where we put all of these various variables and information from our monitoring and our anaesthetic machines and our pumps, and it might be able to tell us where we're flying to and what the likely cause is. And there are some devices that are beginning to do that. So this is the Edwards Life Sciences Acumen IQ, and they have this hypotension predictive index, which they claim is able to inform you that a period of hypotension is going to happen before it actually does. So here you can see the mean arterial pressure is fairly steady, and then it goes down below 65 at this point here. But their hypotension predictive index crosses its threshold of 85 about 4 or 5 minutes earlier. And that gives you a period where you might be able to react, whether it be with fluids, inotropes, vasopressors, to avoid an event that is relatively likely to happen later on if you don't do anything about it. So that's my sort of thoughts on the why and the wherefore of intraoperative monitoring. Why do we do it? It's for safety, to detect deterioration, possible error, and to avoid litigation. Our current practice is pretty good, but there might be room for improvement in terms of capnography in particular. And the future, I think we're going to move away from just trying to prevent serious complications, but trying to use our monitoring in more sophisticated ways to improve outcomes, possibly through artificial intelligence, prediction, and decision aids. I'd just like to say thank you very much to, again, the association, the wider NAP team, so Tim, Richard, Amira, Fiona, and Jazz, the stakeholders who are important for setting the direction of the project and reviewing the cases and currently working very hard to write it up, and to all of our collaborators and anaesthetists across the UK for helping put data in. Thank you very much.